questions than we do answers. But nonetheless, we want to welcome you to this seminar on CPC Plus. Again, we're privileged to have Terry Mills presenting. We're going to put you all on mute. So that way the dogs barking and the paper shuffling and the sandwich chewing won't show up quite so much. But we'll put you all on mute with the exception of our group here and Dr. Mills. At the end, there are a couple of other things that Jolene is going to want to just remind the administrators of. If you're on, we will be having an administrators meeting as we try and continue to learn more about this and what to do. But without wasting any more of Dr. Mills' time, let's get started and ask Dr. Mills to take over and share with us about CPC Plus and his experience.
Okay. Great. Thank you, Dale and Jolene, and happy late May to everybody in Nebraska. Hopefully you all have had some warm weather and lots of rain, so all the crops are happy. I am excited to be talking about CPC Plus today. It has lots of possibility as an add-on both to your practices and to SERPA, and so let's just get right into this. Okay, so we're going to explore CPC Plus, and this is both details about the program, some operational details for your administrators, some clinical and quality details, and then some application details. So we're going to move pretty quick and have a broad overview of all of that. Please collect questions and topics of interest and get those to Dale and Jolene. We'll try to get some focused answers back out to you in the future. So after exploring it, I want to describe the interrelationship a little bit with MSSP, propose a way forward for those who are interested in pursuing this, and try to have some time to answer questions. So it is extremely exciting that round 2 has been announced. Nebraska, the entire state, is included in the other 3 areas that are now being invited into CPC Plus starting January 1 of 2018. Do notice there at the bottom that the application cycle is very quick. If it helps you feel any better, the application cycle for those of us that are in CPC Plus round 1 that started January of this year, it was equally short. The regions were announced in late, like the last week of October, and the applications were due not just 2.5 weeks later. So it's consistent. It is an exciting announcement, and they're looking for up to 1,000 more practices to join. So the question you're probably asking yourself is, you have a great thing going with SERPA-ACO. You've got great leadership, good analytics, good data, and you're doing good work, improving quality, working on costs for your communities. So why would you want to do this? Why would you want to add CPC Plus in what is admittedly a little bit of complication to your practice life? And the answer is basically it's a map forward. MSSP fundamentally gives you targets and helps you understand maybe where you're spending your cost, but then it's up to you. It's on you and the ACO leadership to essentially make all the decisions, figure out all the workflows, and to have success. CPC Plus systematically, programmatically gives you metrics and insight, additional data, and essentially a structure to bend culture both locally and in the entire ACO and to achieve success. Another way to think about it is the ACO actually is considered to be the program, the pilots back when they started, of what to do. We want to lower cost. We want to choose metrics and improve quality systematically. But it really is pretty light on how to do that, right? And CPC Plus was actually started, 5-6 years into the ACO adventure when it was clear that ACOs were not having tremendous success right off the bat. And so CPC Classic and now Plus is truly the pilot program that really tells you the how. And together they have tremendous power. So let's briefly touch on the applications and other programmatic considerations. So we know that, and this is an important definition to read, that the purpose is to test innovative payment models and delivery models to reduce program expenditure while preserving or enhancing the quality. So let's all be very clear in our minds. This is and wouldn't exist if there wasn't a need in the country to stabilize the cost of healthcare, reduce cost, while as a secondary or subsidiary goal also improving the care, or at very least keeping it stable. Remember, the value equation is quality divided by cost, what you get versus what you paid for it. And so if quality stays equal but cost goes down, we're still ahead. You and I and all the clinicians in the world, we want to improve quality as well. CMS has a whole bunch of innovations. MSSP and CPC are two of them. Originally, they had said you were not able to participate in CPC plus while doing an MSSP, and then that quickly changed with the hue and the cry in the country. So here's a nice comparison of the two. CPC Classic was an experiment to prove that the concept worked, that given learning what we learned from the early ACO experience, that given a program with structure, some guidelines, and advancing steps year over year, that it would work. And it did indeed work. CPC in 2015 saved $30 million while systematically improving quality. CPC Plus is a concept in scalability. Now that the concept is proven, they've broadened it dramatically, and they're proving that it can be done on a big scale. So it's gotten a little bit longer. It's gone from 7 to now not 14, but 18 regions. They're trying to get to 3,000 practices. Right now there's about 2,100 some odd. Trying to increase the number of providers involved by a factor of 10. They've gone from 400,000 Medicare patients to an estimated, once the second round is over, probably up above 2 million Medicare patients. They changed the fee-for-service so that in Track 2 of CPC Plus, Track 1 gets full fee-for-service. Track 2, you actually take a reduced fee-for-service at the time you bill, but you get some of your expected fee-for-service spend up front as a PMPM, and we'll touch on that later. They advance the care management fees. Instead of it being a flat $15, Track 1 and Track 2 have different care management fees. There's less shared savings available through CPC Plus. For you all, your shared savings would come through the MSSP. Just like even if you do CPC Plus, as long as you're in the MSSP, your quality metrics are the ACO quality metrics, and your shared savings would be the ACO shared savings. So Medicare clearly has a plan, and the plan is, as I said, to provide a framework to deepen capabilities, change practice culture, give incremental requirements guiding everybody through primary care functions for regular measurable progress, and it really does deliver on that. So we know that first, payers have to apply, then regions are chosen. That's where we now are, and then now you're to the point of deciding if you want to participate. These are the initial regions plus the 4 that have just been added. And here's a map of where all the CPC practices are across the state. It is an impressive experiment in scalability from just CPC Classic. So applicants have to have transformation experience, and this caught some people by surprise. In Medicare was serious about this. What I mean is, to be eligible to apply, have to have basically in the practice at least 150 attributed Medicare beneficiaries. You have to have written support from private payers in your area. You have to be using certified EHR technology in your EHR. And your existing care delivery shows that you assign patients to a provider panel, meaning your patients have an impaneled PCP, that you are actively supporting quality improvement activities. Now, the application doesn't require evidence or proof. You're not uploading spreadsheets, but you are describing existing quality improvement activities in the practice. Given your all's activity in SERPA, that shouldn't be any problem. For Track 2 application, it's a higher bar. You have to be able to essentially tell the story of how you have competence in developing and recording care plans, a formalized care plan, that you have evidence and experience in workflows following up patients systematically after hospital or ED visits, and that you are implementing a process that helps link patients with needs to community resources. Now, again, those are not proof or data. Those are just describing what you're doing. And then lastly, you have to have a letter of support from your IT vendor indicating that the vendor commits to supporting the practice needs to meet CPC+. And we'll touch more on that later. A huge number of IT vendors have already signed blanket letters. They're on file with CPC+, and I can show you where those are. Affiliated practices, and all of you all are affiliated with SERPA. You certainly can apply, but you have to apply individually. CPC, unlike MSSP, which is run basically at a programmatic, SERPA level, CPC is organized and run at the practice level. Each practice in SERPA could be a different track, Track 1 or Track 2, unless SERPA leadership and the accumulated leaders all agree to apply for the same track. We do know that up to 1,500 practices can participate in both MSSP and CPC+. That arm of the experiment, which is meant to be half of the CPC+ experiment, actually had fewer round 1 rollees than the other track, so I think your statistical odds are excellent if you decide to apply. You'll continue billing even though you're in CPC+. Billing will continue through the SERPA tax ID number. Some practices don't qualify. I don't know that any of those particularly apply to you, so concierge, retainer fee practice, a rural health clinic, and FQHC are not eligible. Pediatric practices, meaning if it's a practice of just pediatricians, they're not eligible to apply for CPC+ because Medicare does not, provide pediatric services. However, interesting thing that we're just now actually understanding, once you get accepted to CPC+, your private payers that are participating with Medicare will then send to SERPA or to the individual practices, I'm not sure how it will work for you, individual CPC+ addendum contracts to your payer contracts, whether it's Blue Shield or United, etc. We've discovered that we have some pediatricians in our primary care offices, though they're not on the provider roster that we sent to Medicare, so they're not officially a CPC provider. Some of the private payers are including CPC-like payment for patients in the practice seen by the pediatrician because, of course, Blue Cross covers pediatric services, and they want all of their patients to benefit. So just an idea there that if you have pediatricians involved, they might be able to benefit as well. The application period is tight. It's something that you fill out and then upload. And here is the basic application. Contact information, a site contact, an HIT contact, whoever the IT person is for the practice. You have to delineate individual providers, including address and NPIs. You delineate the number of staff of each type that you have. You describe your organization. You list the TINs that have been used to bill Medicare since 2013, since they look back to January of 13 up through January of 17 to set your baseline. You describe the SERPA-ACO, etc. Describe in detail your health IT, including the specific upgrade version you're on, etc. You describe revenue, so you need some basic 2016 revenue total divided by specific payer and percentage of your patients by insurance type. Most of our practice management systems can provide that information. So there are some care delivery system questions. Patients have to be subdivided by ethnicity and preferred language. They want to know panel sizes, which I think you can basically define either up 24 up to 36 months. And then some letters of support. Letters of support from clinic leadership. There will be a named physician or provider champion at each practice. Parent organization, if you're owned by a hospital or health system, has to provide a letter. The ACO leadership has to provide a letter. They also have to pledge essentially that the care management fees, the CPC plus money, will be segregated, and it may take some banking work. The money Medicare pays for CPC plus must be segregated, independently trackable from other practice revenue, and there are some restrictions on what you can use that for. Now, for all of those of us operating practices, there are all the things you would need to spend it for to hire staff, build expertise is there. For instance, you can't spend it to buy a new EHR, but to hire nurse care managers, et cetera, that's totally up front. To do better data analytics is totally acceptable, and Medicare has that list readily available. Letter of support from the IT vendor, and then a list of all the practices in SERPA that you are applying as a group with, et cetera. Here is an example of the global letter of vendor support. I listed the URL at the bottom, and there are dozens and dozens of them. I did pick out the one for Cerner just because I thought it was interesting, since that's what we use. There are EHR vendors with letters of support that I've never heard of before. That's okay. Interestingly, I did not see a standard letter from Epic, and that has a little jogs a little memory in the back of my head that I've heard from other CMOs that Epic has those letters available but does an individual negotiation for those. So any Epic folks out there will want to get ahead of that pretty quickly. So if your EHR vendor has a standard letter already accepted by CMS, all you have to do is download your copy and then upload it with your application. There is lots of open door forms and information. The first one was actually 2 days ago, an overview of CPC Plus and Q&A, which partly we're providing today. Hopefully some of you were able to listen in. These were fairly helpful. There is typically not a whole lot of question and answer, but if you listen, whoever's going to be the physician champion, your clinic leadership, your clinic administrator, and finance person will want to listen to as many of these as you can if you are going to seriously consider applying. The slides and Q's and A's are usually posted by the day or two after, and there is the URL to sign up for those events. So now let's talk about CPC itself. So CPC Plus is organized around 5 functions, and these are slightly modified or edited from CPC Classic, and that's okay. But the 5 functions, essentially, of advanced primary care include, as you see, access and continuity, care management, comprehensiveness and coordination, engagement of the patient and the caregiver, and then planned care and population health, which go together. We call this the logic wheel, and it's used fairly universally in the CPC and CPC Plus world. It essentially describes everything we do in CPC Plus, and we'll dig into it a little bit more here coming up. In CPC Plus, practices will systematically work to enhance care. See that for access and continuity, that was what we call function number 1, access and continuity. We're going to work on 24/7 access to the EHR from providers covering your practice patients. We'll be sure we have systematic empanelment and assign defined care teams. And for track 2, by the end of the year, each site in track 2 will be offering some alternative to traditional office visits. And there's lots of options of how you do that. For care management, which is function number 2, track 1 practices will risk stratify systematically. We'll have relationship-based care management. We'll have systematic ED and hospital follow-up. And for track 2, we'll use a 2-step risk stratification process, and we'll work on developing more formalized care plans for high-risk chronic disease patients. Now, as you look at those, most of us will say, even before we applied for CPC, we empanel every patient to a PCP, and we have a call group, and the call group can get into the EHR. That's no problem. Our care teams are already defined. Maybe we already do some hospital follow-up systematically. So often you look at this list and say, yeah, that's stuff we're already doing, and by and large that may well be true. So function number 3, comprehensiveness and coordination. Track 1, you identify who is a high volume or high cost specialist referral for you in data that Medicare provides, and you work to improve timeliness of notification of transfers and admissions. And if you're only working with a local facility, that often is a phone call or a sit-down meeting, or it's as simple as you have access to the EHR system, which you probably do. For track 2, you systematically work on behavioral health integration, work on doing more robust psychosocial needs assessments, you work on collaborative care agreements with behavioral medicine, etc., and develop capability to meet the needs of high-risk populations, and you get to pick and define your high-risk population. Okay, function 4, patient and caregiver engagement. At least once a year you have a patient and family advisory council. Now, between you and me, I'll say that if it's done once a year, it's really not an advisory council, it's a focus group. So even for our track 1 sites, we're scheduling them at least in 2 quarters of this year, and then for next year we'll be doing it quarterly at all of my practice locations. Track 1, you assess practice capabilities for self-management, meaning do you have self-management resources, personnel, materials, education around, you pick it, diabetes, etc. Track 2 has a higher standard for the patient family advisory councils, and it requires that you have self-management support, and you can define how that support is and what it works, but you do it for 3 high-risk conditions. Whereas in track 1 for this year, you just are assessing what you can do, and then next year they raise the bar, and then you start delivering some practice self-management support. So lastly, function 5, plan, care, and population health. In track 1, you're going to quarterly review your payer utilization reports, and they come typically about 3 to 4 weeks after the end of the quarter, maybe even 5 weeks. I think we just 2 weeks ago got the quarter 1 ending CPC utilization and quality report. In track 2, at least weekly, the care teams have a team meeting and review population health data. And that's, of course, very broadly written. Any team activity could be written into that, but that's just the concept. The team has to get together systematically, talk about what you're doing, your workflow, your data, and address it. And then lastly, here's that IT requirement that you are using certified CHRT, certified IT. You can use 2014 certified edition this year, but by next year you'll have to be using a 2015 certified edition. There are some quality reporting requirements to be sure that you can filter your CQM data beginning in 18, and then some higher standards for track 2 you see that don't kick in until January 1 of 19. So you can kind of see the HIT upgrade standard and schedule you need to be on if you decide to go for track 2. Okay, so let's dig into the logic wheel. First of all, just notice the blue circle. CPC Plus, after a disappointing initial experience with MSSPs nationwide early, a decade ago, Medicare said we really need to build a program that focuses squarely on better care, better spending, and healthier people, and that is specifically the triple aim. And so that is where CPC Plus helps us go. The top part tells you that there are comprehensive primary care functions, and those are the 5 functions we've just gone over. All of that is wrapped in an organized system for complex care and supported all the way around by aligned payment reform, meaning we're getting off the fee-for-service hamster treadmill, changing the money flows in practice so that you're able to do what your patients and what your community needs you to do, instead of worrying about how many patients have you seen today. The bottom portion of the wheel talks about the 3 enabling, what are called enabling events or functions, which is use of enhanced accountable payment. And that green wedge for your accountable payment is that you're using, now that you're getting non-fee-for-service payment, you're using that monthly PMPM revenue in a strategic fashion, and that you're using it to support and build analytic and data capability in your practice. The orange portion of the supporting functions is optimal use of HIT, so more systematic use of quality reporting, linking with HIEs in your community, and then continually improving your upgrade cycle in your EHR. And then lastly, the red piece about continuous improvement driven by data, and that is essentially something you've been doing in SERPA, and it just means you have a structure for internal measurement of data and regular review, and the culture in the practice and the structure of the practice, the people in the practice are built around regularly seeing that data together, problem solving and advancing improvement based on data. So let's dig a layer deeper. So all that is well and good, and it's great sounding phrases that probably nobody disagrees with, but let's get a little bit into the nitty gritty. Realizing that there's a layer even below this that is specifically how you then report. We've just gone through a month ago our first quarter reporting, and the details of what you have to report is readily available in a CPC Plus manual that I'll be sure that Dale and Jolene have to distribute. So for track 1, you see specifically details that you have to impanel 95% of patients. So proving it requires you run an EHR report that says this is the number of patients and this is the number that have an assigned PCP in the PCP field, and that data you then essentially upload. 24/7 access and organized care teams. We've talked about that. So nobody in SERPA was in CPC Classic, so you won't have the middle column, what we call basically track 1.5. For some of my practices that were in CPC Classic, and now in track 1 of track 1 of CPC Plus, they have some special additional requirements. So track 2, you do all the things in the left-hand column, plus you offer some engagement and service outside traditional office hours. For care management, and I won't belabor these, I'll hit high points. These slides will be available for everybody, and this is straight out of the CPC Plus manual. There are several of interest. Again, I'll be sure those are provided to Jolene and Dale for dissemination. And I wanted to say that at the very front, that this material is directly out of CPC Plus material from the website. So track 1 for care management, you risk stratify all impaneled patients, meaning there's some risk stratification system. I'd suggest SERPA, to the degree you can, use the same system, whatever system you decide on. And it can be as simple as you have high risk and low risk, and high risk is people who've been in the ED or in the hospital in the last 6 months. That's a risk stratification system. There are many that are more sophisticated, but this doesn't mean you have to do something that's electronic and highly complex. If you go to the right-hand column for track 2, you actually need a two-step risk stratification system, which could be whatever system you use, and many of us in CPC Classic and Plus are using the AAFP 6-stage risk stratified care management system, which works well for us. And that just means that there's a second step. So a patient may be AAFP risk category 4, but the care team has a chance to look at that and say, Mrs. Smith, looks like based on the number of chronic diseases, she's a 4 appropriately, but we also know something about her that's not listed in the diagnoses, because of course every patient is more than the sum of their diagnoses. We know that Mrs. Smith is frail and elderly, caring for a husband at home who's bedridden, and she has nutritional challenges or lives in a rural food desert. So actually she's maybe risk 5. So it's just the idea that there's two steps for risk stratification. Let's see, track 1 for care management, you do episodic care management. You ensure patients have ED follow-up within 1 week and have to be able to track that percentage of patients that you spoke to within a week. The CMS language here is that you achieve a, quote, high and increasing, unquote, percentage of ED follow-up within 1 week. There is not currently for this program year a numerical definition you have to prove. I expect there will be for 2018, which will be our year 2. An open question that you probably won't have answered before you apply is, for those of you that next year is year 1 for the second round, will you have a numerical target for ED follow-up? Then lastly, that you follow up 75% of patients hospitalized within 48 business hours. That's the contact required, of course, to be able to build the transition care management codes. That has great revenue benefit to the practice. Comprehensiveness and coordination, track 1, that you identify through a report, through some algorithm, et cetera, you identify whoever your high cost and or high volume referral specialists are serving your population. And that could be using CMS's data, it could be using Blue Cross's data, it could be using MSSP data that you have. So it's just saying that you do it, and then what you do with it is up to you. I would expect that program year 2, there would be a higher standard. They're going to want to start seeing movement on that. 3.2 is that you identify hospitals or EDs responsible for most of your care. That should be fairly straightforward for you all. And that you just work, that you assess, you know how timely you get notices from them of patient presentation, and you work to improve it. If you already get real-time notice that your patients are in the ED or hit the hospital, then you've already done this. Again, middle column, track 1.5 doesn't matter to you, but track 2, you have a collaborative care agreement with at least 2 groups of specialists. That may be if you use hospitalists for those that are in more urban areas, it means you have an agreement with a hospitalist about how things go, communication, timeliness, etc. It might be your cardiology consultant that you use. Just you pick 2 groups of specialists and you outline the relationship and the expectations both directions. That's often just a 1-page document. The reporting guide asks if you're using AAFP, ACP, AHRQ, I believe, and a number of organizations have basically templates for collaborative care agreements that you can just use. I wouldn't bother to try to make up your own. 3.4, there's a whole menu of options for integrating behavioral health. 3.5 is that you systematically assess psychosocial needs for your patients, and that of course requires your EHR has those tools available. For this year, for track 2, 3.6, is you do an inventory of what resources you have to meet a patient's psychosocial needs, such as mental health conditions, grief, bereavement, food, nutrition, support needed, etc. And you just have an inventory and like a list of resources available systematically. And 3.7, you understand needs of different subpopulations in your practice. And again, that's it's really pretty open to how you define and act on that. Okay, function 4, patient caregiver engagement. We've talked about the patient family advisory councils. I'll give them a plug. They're really a great experience. You all may have done that at sites. It is very useful, actual intelligence about how things actually work in your practice. Talk about wanting to be efficient and effective and serve our community's need, often without having ever asked the community or patients who are in the practice what they perceive and how we could do better. So that's really a positive experience usually. 4.2 for track 1 is assessing our capability for self-management support, basically doing a SMART goal, asking patients, how confident are you can care for your congestive heart failure or diabetes or whatever, and then building some materials, education, training, referrals around that need for engagement. So on track 2, the right-hand column, have to do PFAC in at least 2 quarters, and then implement self-management support for 3 conditions, and you get to say what your high-risk conditions are. And lastly, plan care. CMS wants you to use the payer feedback reports, and at least quarterly, and you pick 2 utilization metrics. And since we know that this is all about reducing cost while maintaining or improving quality, the cost is often in the hospitals. So you may choose to help work on access and fast track with your local ED or something to keep patients out of the emergency department. So that's a utilization metric that has a whole lot of cost associated with it. In a way, you can prove that you're meeting community needs and saving cost. For track 2, you conduct care team meetings at least weekly and review anything in the practice. Data means workflows, internal CQM data, MSSP data, payer data, etc. Just you meet weekly in your care team and engage on that continual improvement cycle. That really is kind of the foundational cultural adaptation that we have found in CPC Classic that we've instituted in all of our sites. Our brand new sites in Track 1, their team meetings, and this is everybody offline, including staff who remain on the clock. You don't schedule patients. You're in a team meeting to address practice needs and data. For our new Track 1 sites, we're doing it every other week for the first 6 months, and then it will go to weekly. Our Track 2 sites, which we're in CPC Classic, we're doing weekly for the last 2 years now, and they continue doing that weekly. And then, let's see, sorry, I went backwards. And then there's very helpful guidelines, so that's what's required by the end of program year 1. Those things we just went over are not required immediately for your first quarter of reporting. There's this really helpful chart, and this is the one for care management, that gives you a plan to pick priorities as you work on operations and improvement. You want to say, you know, it looks like ensuring that ED patients have follow-up within 1 week is pretty high priority, so we're going to start working on that quicker, and within 4 months we'll try to have a process and reliable data, right? The one at the top about testing risk stratification, maybe you can not work on that as hard or delay some preliminary goals, and you just have to have that accomplished, you know, by the end of the year where you can prove it, so you really want it done by October or November. So there's a really nice glide map like this that helps you know when to phase things in. Now let's talk about CPC Plus payment. And this can be a little bit confusing. Some of it's straightforward. The comprehensive primary care payment can be a little bit confusing. Big picture, there are 3 buckets of payment in CPC Plus. The first, and this shows you all 3. So there's a care management fee, and that's per beneficiary per month. So and that's meant to augment. So it's non-fee-for-service billing that's reliable, reproducible revenue every month as a PMPM based on your attributed patients. For Track 1, it averages $15 per member per month. For Track 2, it averages $28, except for your highest 10% of HCC score and all patients that have dementia. They get $100 per member per month to the practice to be able to engage and meet those high-risk needs. I'll have more details about how that works coming up. You see your performance incentive payment. This essentially replaced the shared savings, which was in CPC Classic. If you're in the MSSP, you don't qualify for the CPC Plus incentive payment. Your incentive payment would be the MSSP shared savings that you either earn or don't earn. And then the payment structure redesigned for Track 1. This is the what you get paid for actually seeing patients. For Track 1, it's a standard fee for service. For Track 2, based on thresholds you pick, you shift some of your expected annual fee for service payment into a PMPM, and then when you bill for each patient visit, you get a reduced fee for service payment. And that is just meant to get us off the fee-for-service treadmill and to reduce dependence on the visit being the central focus of your care. So it truly frees you up to say visits and access should be used for patients that medically need a visit. And maybe people that are calling with cold symptoms, we don't need to drive into visits. There's other ways to handle that more effectively, more efficiently, cheaper than requiring everybody with a cough and a mild sore throat and no fever to come to the office. Okay, so here's back to the care management fee. So this is the first of the 3 buckets. So you see that the 3 risk tiers for Track 1, they're basically quartiles of HCC score. Your first quartile is $6, then $8, then $16, then $30 PMPM, and that averages $15. So this makes it clear that the HCC RAF score is even more critically important, if that's possible, in CPC Plus than it has been in your MSSP. For your MSSP, the severity score simply sets the benchmark you have to perform below to prove you're reducing cost. And so essentially it equally or more powerfully defines whether you actually reduce cost and receive shared savings than actually lowering the cost, right? In CPC Plus, that risk stratification actually affects revenue that you're receiving right now. In Track 2, there's 5 risk tiers. So basically 90%, the lowest 90% is split into four equal parts basically. Actually, I see now that I forgot that they carve 10% out of the 4th quartile. So the first 3 quartiles are $9, $11, $19. The 4th quartile, which is shaved down, is $33, and that highest 10% in dementia is $100. The reason dementia as a diagnosis is included separately is because currently HCC does not include dementia as an HCC bucket or category. When CMS revises that next, which is expected next year, I'm sure they will add an official RAF score for dementia. So that is no beneficiary cost sharing, so that's a payment directly to you. The risk tiers are relative to your region. So your region is, CPC region would be Nebraska. So all of the Medicare patients in Nebraska, your risk tiering would be compared to the risk tiering in the entire state, basically. So here's how that money flow works. I just quickly modeled practice XYZ. Imagine you had 5 providers, 2,000 patients apiece. There's a fairly standard payer mix. So you would see that for your 4,000 Medicare patients, if you were in Track 1 at $15, that's an extra $60,000 a month, per month. So Blue Cross, your private payers, would likewise have some sort of care management fee. Every private payer has a different contract with different amounts. They have to follow Medicare's system. Medicare's, what they offer has to be similar. So they're following Medicare's lead, but they are free to set their own amounts and their own policy about what they pay for CPC Plus. It's pretty common to see something from a private payer like $2, $3, $4, rarely $5 PMPM, and some shared savings component, at the private payer's methodology. I have heard of several private payer contracts aren't paying any care management fee and just have a richer shared savings possibility. Some private payers will say, okay, Track 1's not advanced, they're building infrastructure still, so they'll provide a PMPM care management fee for Track 1, but for Track 2 there won't be a care management fee. There would just be shared savings, because if you're in Track 2, you're already saying you are more sophisticated and farther down this journey, right? So there's lots of details there to figure out. But for this very typical payer mix, and the revenue per month with very realistic numbers, noticing I have 0 PMPM from Medicaid for care manager, which is not atypical. You see it's an additional $73,000 in practice revenue, almost $1 million a year in additional revenue. To hire staff, better upgrades for your IT, better analytics, the things you have to do. For Track 2, you see corresponding higher amounts. Obviously, if you know your risk tiering, your HCC tiering, you could make your Medicare revenue data more accurate because you'll know exactly where your HCC scores break down. Okay, the second bucket, this performance-based incentive, this is just to show you how it works. As I said, in the MSSP, you're not eligible. Your shared savings comes through the ACO. But it basically says, for Track 1 and Track 2, they each get a quality and a utilization PMPM, which is paid quarterly prospectively, but then at the end of the year, and actually the final reconciliation is going to be 3 or 4 months after the end of the year, then it's trued up, and if you don't meet the goals for either quality or utilization, you pay the money back. It's reconciled. So obviously, if a person was doing this, they would receive that money, sequester it, not pay it out or spend it until you knew you were going to get to keep it. And there's more in that for Track 2 than Track 1, but not a significant issue for you. And you can see, compared to the care management, this is the same practice, same patient, payer distribution. You can see that the potential money involved in the incentive payment for CPC Plus is much, much smaller than what you get in care management fees. Okay, so this is the complex part. This is the third bucket, and this is the comprehensive primary care payment, so CPCP in In CPC Plus, there's a whole lot of new acronyms to learn. I think they already have a 2 or 3 page FAQ about the various acronyms. So right now, last year you got fee for service. If you're in CPC Plus and you choose Track 2, so Track 1 this doesn't apply. Track 1 continues to get 100% fee for service after every billed visit. Track 2, your total expected annual billing, and they average, I believe, the last 2 years to get that amount. There's a specific list of codes included in that calculation. It's basically the E&M codes, the Welcome to Medicare visit, annual Medicare wellness visits. I believe the transition care management visits are included. So certain codes average the last 2 years of expected billing. Then they inflate it by 10%. Then out of that amount, you choose a ratio. Starting from low, like I think the lowest is 25%. The highest is, I believe, the first year is 65%. You would then shift your expected billing. They divide it up. So if you choose 40%, you take your 110% of billing, you multiply that by 0.4 to get 40% of that expected inflated revenue. Medicare shifts that to a per member per month. So you divide it by 12, and they send that to you every month, whether you see the patient or not. Then when you see the patient, you bill the standard CPT codes, and you receive 60% of the usual allowable charge for that visit. Each year in CPC Plus, if you start with a lower PMPM and a higher billed visit split, each year they shove you to the right, so that if you choose 25%, the next year you have no choice but to go up to 40% or higher. Over time, everybody's going to wind up at one of 2 places. And currently the most aggressive is 65% of expected annual billing is coming as a PMPM, which is what St. John chose. And then we're only getting 35% when we bill the visit. Obviously, if you're managing your care and your utilization stays the same or decrease, you come out ahead. If your utilization gets worse and suddenly for some unknown reason you're churning visits and your average visits per patient goes up, then actually this hurts you. So you kind of have to consider that math fairly carefully. Here's a spreadsheet of how that might work. So same practice, $630,000 is median Medicare billing for family medicine according to MGMA, times 5 providers, assuming they have the same Medicare population. That's your Medicare billing in a year, allowable charges. You inflate it by 10% to get 3.465. If you chose this year the 25%, then you would be getting $866,000 of your expected annual billing as a PMPM, and that divides out to $72,000 a month. You'd get the remainder fee for service. If you chose the more aggressive, 65%, then you see you get more of your expected annual billing up front divided as a PMPM. So that's how that works. Some of the FAQs about this are a little bit confusing. Sometimes it reads like they contradict each other. That's the cleanest example of how the math works to my knowledge. Okay, we've talked about this, and this is just for additional details. Won't belabor that. I think we've gone over that. So the financial impact can be very significant. Without breaking confidence or giving specific numbers, in the primary care group that I help operate, in CPC Plus, compared to just last year, we've seen, realizing about half my practices were in CPC Classic, the other half were not, so I doubled the group that's involved in getting care management fees. Our revenue increased very significantly. Once you do the math of what each private payer offers, what those care management fees are by the number of patients, and every patient attributed by any provider in CPC Plus is getting that care management dollar, et cetera, it has a very significant impact of your money flow. This is the factor that tips primary care cash flow into getting you off of CPT-driven fee-for-service medicine. The House of Medicine and Primary Care has been saying for years, including myself in lectures, including some in Nebraska saying it's coming, it's coming, it's coming, get ready. I can tell you for at least my primary care group, it happened this year that non-fee-for-service revenue now is greater than fee-for-service revenue, and that really does very fundamental things to practice that are for the benefit. There are some really good YouTube videos that explain individual pieces. So this gentleman is talking about the payment innovation, and there's one about care delivery transformation. Each of them are about 8 minutes, 8 to 10 minutes. I think longest is 15. So those may be useful as you consider it. Just hit YouTube and check out CPC Plus. These are all done and released by HHS, so these are the official explanation videos. Okay, operations. So everybody's impaneled to a care team. You'll want to have clear what the role. Each site has a physician or provider champion. It can be an advanced practice provider mid-level if you want. You'll want to define, this is what we use. This is our descriptions of a care team defined as the clinic site that cares for patients together. So the manager has a role, each team member has a role. So the care team includes everybody, even the MA, the MAs and PSRs are frankly often the most important members. If you're using a lean toward an understanding of flow, you want the people closest to the work to help find the solutions. And most workflow problems in a practice that aren't specific medicine related are happening while docs are in the exam room. All the administrators are well aware of that fact. This is just an example of a list of physician champions at each site. This is a list of the types of things out of our care management funds, out of our non-fee-for-service revenue that we didn't expect because, compared to just what we would have billed for services. These are the types of things you may consider adding to your practice. Some of this could be shared around multiple practices. If there's, 4 SERPA practices in a reasonable region, maybe you split an ambulatory pharmacist who's at each site, one day, and then working lists for counseling certain patients the 5th day. I mean, there's many ways to slice it up, but this is the type of people you're able to add to a practice. People often say, so in CPC team meetings, what do you do? What do you talk about? And admittedly, this is a 5 or for a year, maybe 4-year process, right? So don't necessarily worry that you have to learn how to do this, because that's part of the process, is learning how to run a team meeting. And we even start with training like trust in communication, training to be sure staff know their voice is needed, respected, understood, training providers to try to speak last, all those types of things. These are topics we've used in our team meetings broken down by function, and there is way more than a year's worth of weekly team meetings to improve your practice in this type of arrangement. And then the CPC Plus online community has reams and reams of information, examples of these topics, things, care pathways from other systems, et cetera. So there's lots of resources in the CPC infrastructure. There's also a CPC Plus document called the Change Package. It's about 60 pages. This is an example of some of the stuff in the Change Package. So it says, okay, if you want to assign and adjust risk fact statuses for each patient, here's the way you may do it. You define a method, you define data around that, you then find a way to regularly, check back on your risk stratification and adjust it for your high-risk patients. So the Change Package gives you ideas for each of the 5 functions of things you could do, either SERPA-wide or down to the practice site. So that's one of the resources available. So what do you do first? Organizing team meetings, coordinate with champions, kind of establish ground rules and process, build a foundation of how to run good team meetings, see what data you have available, etc. PDSAs are a very foundational thing. You actually have to use PDSA and upload on your quarterly reports to CPC Plus. You upload examples of current PDSAs. Here's an example. There's many available. You don't have to use a certain one. This is just an example of a PDSA template. Institute for Healthcare Improvement has a slightly different template that can be used. So the format's not important. It's just important that you really do have a process. You do use that format to help guide the team meetings, etc. Often teams find doing PDSAs in a more formal written process is cumbersome. It seems kind of silly, yet that is exactly the self-discipline of defining what metric you're going to use for the next 3 days, from which providers practice, how you're going to do it, and then get back immediately that third day or next week and define what happened and what do we do different. Frankly, it was that formality that once we worked through it is what helped us start getting traction to actually change things. What you work on after that is risk stratifying, and then you work on your CQMs, which for you are the ACO CQMs. So clues to success, remember that every improvement requires a change, but not every change is an improvement. It's a pretty foundational thing. People want to keep looking at data, wishing it gets better randomly next month, and that's not a recipe for success. You go small. Think about what you can do for 3 patients tomorrow to try out changing a process. And often you want to go through 5 or 6 stages of hierarchy before you do something practice-wide. You want to fail often and fast, because you don't learn anything doing the same old thing. You only learn when you try something that didn't work like you thought and you make it better. That's how change happens. Realize that all of the practice managers are now having heartburn, because that is antithetical to good practice management, which is to be efficient, maintain a healthy status quo. Don't start changing stuff and make it screw up. So there's really some conversation to be had with practice managers about how to do this, because you really can't crash the car, but you do want to tinker with the system and make it better. This is a really, really, really useful paradigm. As you start talking to things and you see confusion, confusion usually means that the team is missing the vision. What's missing is blacked out. If there's confusion, there may be incentives and resources and an action plan, but people just don't know why they're doing it. That causes confusion. That means the vision is not communicated. If, for instance, there's no action, people have the skills, the vision, the incentives, and the resources to do something, but you start and nothing works and it's rough and you keep trying again and trying again, there's no plan, there's no action plan to know how you're doing it. So this is just a useful paradigm. Lots of resources. This is the CPC Plus webinars I mentioned. Here's an example of the CPC Plus Connect community that has resources available. So back to the why. Why are we doing this? MSSP is a great program. It gives you data, and you share in the shared savings of your success. Well, why you do it is because it gives you a roadmap, and both quarterly and year over year, an incremental process to steadily improve your practices and your results. And it does work. CPC Classic proved that. There's intermediate steps and concrete goals. You're doing quarterly reporting, and the quarterly reporting is actually about the steps that go into building the house that works. You are guaranteed upfront revenue. The Faustian bargain, the hard thing about MSSP is you got to do a lot of stuff and spend money now, and maybe you'll get some shared savings later, and maybe you won't. That's hard in a fee-for-service world. And finally, CPC Plus breaks that paradigm and allows you to do that, to hire people, build infrastructure that you need. It has very transparent incentive payment possible. Again, that's not for you in the MSSP. Your incentive payment is the shared savings. For Track 2, why you do this is your Track 2 fee-for-service revenue that you're expecting is actually inflated 10%. And then if you actually lower your utilization because you do some online asynchronous visits, or you do group visits, and so your actual visits per patient goes down, you might actually wind up receiving 20% more than expected revenue. And then this is multi-payer. Don't underestimate the power of having your private payers involved in this and getting non-fee-for-service money for them. I don't know which private payers are involved. I failed that list last night for Nebraska. I'm sure that Jolene and Dale know. That is really powerful in that it is aligning the revenue and the forces for all of your patients. And I should say, by contract, what you build is not just for one payer. by contract with Medicare, what you build in CPC Plus, you run whole population across your entire practice. And frankly, that's the ethical litmus test most providers feel good about. We know we want to do the right thing for every patient, not just Medicare's patients. It also helps operations because it's very, very hard to manage a list of patients of who needs what, or look at the diabetic quality for just my Blue Cross patients, et cetera. That's not very functional. And so this lets you just focus on your entire population. So CPC Plus is a paradigm to help give you the tools and the personnel to powerfully row the boat forward and achieve reduced costs and better outcomes for your community. It's been a positive experience here at St. John, and I'd encourage every practice to think about it. And I greatly appreciate your time. I'll be happy to take, I see one question already that I'll address, and then answer questions and get materials back to Dale and Jolene for dissemination. So the question from Nicole Palema is, care management fee money flow, how do you know your PMPM from Blue Cross and Blue Shield and United, your private payers that are involved in CPC Plus, and that list is known. You can search for it today on the Medicare website. Every private payer will give you a CPC Plus contract addendum. So we found out we were in CPC Plus January 19th. We got the Blue Cross contract addendum late in February. We got our United contract, CPC Plus contract addendum in early March, and we're still, working through those. About, probably about to sign them, and you certainly don't get their money until you've got the signed addendum. But it comes as an individual contract addendum to the practice, or actually, good question, Dale and Jolene, that might be to SERPA. We'll have to, probably is to SERPA based on the 10. We'll have to think that through. But it is a individual contract that has the details. Couple quick questions. What do we use for analytics? We have most of this is driven by your EHR. So we're on Cerner. Yes, we have a single EHR across all of my health system and all of my practices. Each EHR vendor has a package, an upgrade package that's required to then run your CPC Plus CQM reports. All population, Medicare requires that it be unvarnished, unadulterated data, raw data out of the EHR, and you report it to Medicare for all population. So you're not segregating it out and reporting individual payer data. You report it all to Medicare. And most of that, the majority of it comes from our EHR, which is Cerner, and then we also, our risk stratification program is a discrete field we built into the EHR, and we just put number 1 through number 6 because we use the AFP risk stratification methodology. Cerner doesn't report that, so we built a SQL server report to generate that data for us. Let's see, yes, the analytic package has to be from your EHR vendor. Ed, if that answers your question, and every EHR has or should have a CPC Plus upgrade that's required. You want to communicate with your EHR vendor. If they say, no, they can't do it, then you're pretty much out. Difficult to separate, question from Patrick, difficult to separate out and account for the PMPM payments. A little, but your CFO can, your CFO or practice manager with some guidance from your accounting team can do it. It's simply required that we receive, and you tell what account Medicare is going to send that to, right? You give the account number to your private payer vendors. They send the PMPM to a specified account. So we had to set up a new account in our book of accounts and segregate it that way. The question about control groups, I'm not sure I understand. Let's take that one offline.
I think what that is that we will apply and we'll either be put in control or you'll be put in an intervention group. CMS makes that decision.
I'm unfamiliar with that.
That's a new thing out of CPC Plus round 2.
Okay, so I don't know that detail for the round 2. My experience was you applied for CPC Plus and you were put in or you were not put in.
They'll put you in, or they'll put you in a control group, and then they'll also determine which track you are. I mean, you apply for the track and that. So.
Right. Yeah. And if you apply for track 2, they ask you up front, if they decline you for track 2, do you want to be accepted as track 1? So that's something to think through. In our market, which is all of Oklahoma, there was a lot of chatter among the CMOs about this. It seemed like the most common reason groups were not accepted to track 2 that really probably were ready is they didn't answer yes or positively enough to the application questions about those 3 functions that were unique, about being able to do care plans, having team meetings, etc. So those things you have to be able to do on one of my early slides, 3 of them are unique to track 2, and it looks like the pattern is you have to essentially answer that yes, you can do those things all the time to be accepted into track 2. Well, I'll kick it back to Dale and Jolene. I think we're out of time.
There was one other question that's from Dr. Hodovy. It's, what were your biggest challenges your clinics experienced? Could you answer?
Oh, that's a great question, Patrick. I appreciate your asking. Variation, and I'll explain that. The greatest difficulty, which one would hope you will experience less, having been in the SERPA culture and workflow for now 2 years, going on 2 years plus, is variation. You know, you say, well, clearly you look at our data, the ED data is high. We do some root cause analysis that seems to be about access to same-day appointments and about patients knowing they should come to the clinic, you know, during business hours or our 5 to 7 p.m. walk-in clinic instead of going to the ED. So those 2 problems. You then go clinic by clinic to try to deal with those 2 problems, and you immediately run into 1,000 variations in workflow and culture and yes, but. Yes, we could do that, but. So having a really clear vision, you know, you want to look at Simon Sinek's YouTube TED videos about start with the why. Get really clear why everyone is doing this. Get really clear how centralized or decentralized you want to be about, you know, kind of internal goal, you know, benchmarks and metrics and workflows quarter by quarter. And then figure out your governance structure. How is it going to be governed? Because between you and me and the fence post, if there's 25 clinic sites in SERPA, there's not 25 best ways to do pre-visit planning for a diabetic. Maybe there's 2 or 3. And how are you going to find those and disseminate that to systematically move the quality of your diabetic care if, for instance, that's one of the high-risk conditions you choose? So variation in culture and workflow is our biggest challenge, and we're still living through the solution currently.
And do you have time for one more question, Dr. Mills?
I do. I have time if you do.
Okay. This was, how do you control costs when you don't control the patient or the outside facilities? Because we're all independent clinics, and then we have the hospital that's, you know, independent also from us.
Right. Does everybody remember my slide in a prior talk which showed a left and right frame? The left frame is a guy on an island looking out towards a boat saying, yay, a boat. And the right frame is a guy in a boat looking towards an island saying, yay, it's an island. And I think the answer to that question, without trying to be overly cute, is it's about perspective. So it is easy to say, oh golly, our costs are really high because we don't control the hospitals and the ED, and it's out of our control. It's hopeless. And I will certainly readily admit that's a challenge, and there is an element there that you are absolutely right. You can't control that. At the same time, build a better mousetrap. It doesn't matter that you can't control the cost if your patients never present to the ED. So what's your, you know, how many hours a day do you have access for your patients? And that doesn't mean a visit. Maybe it means on call. Maybe it means the walk-in clinic. Maybe a group of SERPA clinics in a region open a fast-track urgent care next door to the hospital. Maybe you rent 2 exam rooms out of a hospital and do it there as an alternative to the ED. You just got to think really creatively. Since you're getting care management fees, some of the billing constraints aren't necessarily important. and you just figure out how to build a better mousetrap, you control that cost by preventing the patient from ever getting to the ED or the hospital to start with. And if clearly that doesn't mean that you're not going to have car wrecks and sick babies, there will still be hospital care, and once they're in the facility, you can't control the cost. But if you look at data about ambulatory sensitive hospitalizations and readmissions, if you can simply prevent even a portion of the patients hitting those sites of care that should be in our control, you'll be a rock star, because that controls tremendous cost without worrying about at all. Have no heartburn about appropriate hospital visits. That's okay. And then there was a good question about HCC score update, and I want to touch on that. Your HCC scores are set once a year, and prospectively, it's set by Medicare prospectively. You provide for a year, you provide care, you keep coding diagnoses, Medicare then accumulates them at the end of that year. They'll update in some fashion for the following year. I think there's a pretty good lag in Medicare updating the HCC score because, of course, you know, for the end of things you coded up through 2016, that's not adjudicated till late summer of this year, and that may not be in place ready for 2018 payment. So there's a pretty good lag, but it's updated once a year. Attribution. There's a wrinkle here in that Medicare has reserved the right to take a patient out of your attribution if the data says the patient is seeking primary care elsewhere or you haven't seen a patient in the year. They drop out of your attribution quarter by quarter. But you only add patients that you see new in your practice. You only get additions to your attribution once a year. So Medicare has rigged that portion of the game to their advantage, and that's just the way it is. Now I know since attribution and a yearly visit is so critically important for the MSSP that you probably are already doing a very good job seeing patients at least once a year. And if you do that, you won't really have any problem with attribution.
Okay, I think we're done. I think Jolene has an announcement for the administrators, if anybody's still on administratively, that there will be an administrators get together to talk a little bit more about this on...
It's on June 6th. I'm still trying to locate a location and the time, but we will be having the meeting on June 6th. That's what many of you guys said would work for you. So we will continue this conversation there for the administrators or for anybody else who wants to attend that meeting. So, otherwise, we want to thank Dr. Mills again and appreciate his input. I, like many of you, I suspect, feel like I've just had another dose of the fire hose rather than the soaker hose. And so hopefully we can, these slides will be available. This meeting will be available on Basecamp. So just to let you know that that's our plan. And thanks again for attending and being a part of this. We may do our next session will be in June sometime. We will determine the topic. It might be CPC plus second round. Well, otherwise there may be something else that we talk about. But we'll have Dr. Mills speaking again in June sometime, and we'll get that date.
I think the CPC plus is a really good idea to head of part 2.
Okay. So we may do that and continue with the questions. So.
Thanks again.
Thank you.
Thank you.